Excellent. So this is it. This and identifying what needs, how we need to be able to show what nursing does, because we've never been able to describe nursing
Right.
as a strong value and a strong member of the team. We don't cure. We don't cut out the, we don't do the operation. We
Right.
don't do that. But without nursing, and we've always
Right.
said that, but it's always been an ancillary.
Right.
Now it is like a partner. You're identifying it as a partner.
Okay.
Now you want to you had here, did you want to talk about that?
Well, another innovation in healthcare education is the use of simulations to teach students how to react in certain crisis situations. And most often are medical situations, but sometimes they're psychological crises as well. And you and I went to a conference of military nurses who were working with nurses about to be deployed to Iraq, where there was a lot of traumatic brain injury and body parts that were blown off, and a lot of psychological crises, in addition to the medical emergencies. And so these simulations have become a way to teach nurses across settings about how to handle different clinical situations. And we actually talked in that conference about integrating the comforting interventions that accompany the medical interventions, or the physiological interventions, or even the medications that are given. Our comforting interventions are also being integrated into these simulations. So that's another exciting
yes.
avenue
Yes.
for applying comfort theory. So how would you script the ideal response so that the nurse who is learning realizes that the comforting words and actions are very important too? It's not just the physiological actions and medications.
It's the
And
whole,
diagnostics.
It's the whole nurse response.
The whole response, and to not relegate the comforting behaviors to to be something that isn't important. So this elevates those kinds of behaviors again.
Excellent. That's exciting.
Yeah.
Yeah, that is exciting. You also, on your last interview, you ended up with talking about palliative care, and I think it was geriatric care, but I'm not sure, those last two. And you have some initiatives, or you have some vision for this about what you were going to do with that.
Well, palliative care is a perfect setting for comfort theory because palliative care is so holistic in its conception. So it's just a perfect fit because it's all about symptom management and all symptoms: anxiety, family stress, spiritual angst.
And isn't it one of the comfort? Isn't comfort one of their mandates somewhere in there?
It's in their scope and standards of care to provide comfort, and as well as in hospice. So and then with the ACE model that is still popular and still being is growing across the country, acute care for elders. The ACE nurses and myself published an article about the integration of those two models quite a while ago, and that is detailed in the book and on the website. Yeah.
Okay. So you've identified your future plans. Are there any others that you are wanting to talk about today, and your vision for your
Well,
family?
I am hoping to reach graduate students and practicing nurses through this audio tape, and to ask you for your ideas. I'd like to know what you need to make this theory more accessible, understandable, usable on your unit. So I'd like to hear from you, and for future suggestions in regards to technology or other things that I haven't even thought of yet.
And in addition, in homes too, in the community.
Well, in community nursing, in programs that churches build for to be a support in the community. It would be wonderful if the next healthcare policies that come out of the Obama administration have some of these holistic aspects to them. I'm hoping for some form of universal coverage. Up in Canada, I've worked with Canadian nurses who have used the theory in the community because they have the luxury of being able to treat the whole community,
Yes.
regardless of how much money any individual family has. What a luxury that would be in this country for our public health nurses and community nurses. So I guess I have tried throughout this whole program of research to respond or anticipate the newer trends that are coming along.
Yes.
I'd rather anticipate. I'd rather just kind of feel an intuition that, oh, I need to go in this direction, rather than just be reactive. But both ways work. And I'm just always have my ears and eyes open for what needs to be done next with comfort theory.
And that is really true. I believe you really have advanced the theory because you are on the page early on to wherever whatever is happening. And the changing healthcare system has changed dramatically,
Yes.
even in the past
Yes,
7
it
years.
has.
And where it's going, nursing education is going to change dramatically. The needs are changing, and somehow you have been able to see that's something that's important.
Yes.
How does comfort relate here?
And the advantage of having a website is that I can make the changes on my website right away. It takes 3 years to get a book published. It takes 18 months to get an article published. But with my website, I could just put it out there and say, what do you think? You know, is this something that will be helpful? I am contemplating writing a second book with all of these, an update
Yes.
to encompass these topics that we've talked about today. But again, that would take a long time, and I'd rather just talk about it.
And it also serves because you have a board of advisors. People on your website
Right.
say, what about this or what
Right.
about that? And so you do have, many peers have a board of advisors, but your advisors come from your website, don't they?
And of course you.
So, well,
I will say to my audience, Therese has been a wonderful critiquer, analyzer, and fine-tuner of the theory in the whole 20 years that we've worked together. So,
isn't that amazing? 20 years.
yes.
So I want to thank you very much, Kathy. This has been just fun.
And thank you to the University of Akron for helping facilitate this.
Yes.